Hello everyone, my name is Sara. I'm a third-year medical student at Albany Medical College, and today I'm here to talk to you about child and restraint study in emergency ambulance transport, or as we like to call it, CARSEAT. Here's our list of authors, and we have no pertinent disclosures to make. In 2018, there were 30.9 million transports. 1.5 million included children. Of note, New York State is one of only 29 states which do not mandate pediatric-specific transportation devices be carried on ambulances. Inconsistent use of restraints on patients is a common problem, which can lead to injury during transport. Crews may lack the education, experience, or necessary tools to safely restrain a child during their transport. CARSEAT was a retrospective observational study of EMS ground transportation. Analysis of existing security footage of the Mastery Family Children's Emergency Center during the first year of operation allowed us to analyze ambulance crew entrances. Entries were retrospectively matched with chart data using date and time from the ED tracker. Patient metrics were then uploaded to Research Electronic Data Capture, or REDCap. Available footage of crew arrivals was then time-matched to patient admissions for review. Volunteers with medical and EMS experience were trained by a CPST for EMS on topics including pediatric transport adjuncts, device weight guidelines, and appropriate device application. The infants on either side are appropriately secured, while the infant in the center shows inappropriate chest retainer clip, shoulder strap, and headrest placement. This child is in a properly sized car seat, but her bulky jacket and low chest retainer clip placement are incorrect. Reviewers completed survey evaluations of assigned videos in REDCap. A sample is shown here. Surveys ranged in length, with two main questions. One, was the device used appropriate for the patient based on weight guidelines? And two, was the device applied correctly? Correctness was based on best practice recommendations and industry weight-based guidelines. From a total of 4,701 EMS transports, 3,616 video entries were able to be reviewed and assessed. Approximately 54% of patients were transported in a device that was appropriate for them based on their weight. However, only about 23% of patients had that chosen device applied correctly. This is a depiction of the various devices and adjuncts used. Upon further comparison, the vast majority of patients, about 63%, were transported on an ambulance cot only. Of note, 8.3% were transported in an infant bucket seat, which is not designed for the necessary 2 points of attachment on the stretcher. 7% were transported in an EMS-specific pediatric safety device. Of that 7%, 89.3% utilized the Furno PediMate, which has a weight range of 4.5 kilos to 18.1 kilos. Finally, about 2.2% were transported on a caregiver's lap. This is a visual representation of the age distribution of our study population. As you can see, less than 1 year of age contributed the most, about 11%. 9 years of age contributed the least, at about 3.5%. Overall, we are better at selecting the appropriate device when the child was at the far ends of the age range. This can partially be attributed to weight, as once a child is over 45 kilos, the transportation device of choice is simply a stretcher. However, this trend does not hold true for the proper application, as across the board, regardless of age, we are uniformly bad at appropriately placing children in the correct device. This is a visual representation of our patient ESI distribution. Again, our data demonstrates that although we at times have over 50% appropriate device selection, we struggle with correct device application, hovering at just over 20% regardless of patient acuity. 45 kilograms represents the point where patients can be appropriately transported in a stretcher without a transportation adjunct. As you can see, we have excellent device selection for patients over 45 kilos, but struggle with those under 45 kilos. Additionally, for both patient populations, we continue to inappropriately secure patients. From the data, we can see that about half the time, providers are selecting the appropriate device for the patient based on their weight. However, we are substantially less likely to make a correct selection for our lower weight and younger patients. No method currently exists to properly and safely secure an infant bucket seat to the stretcher, yet it was the second most used adjunct in our study. We are still transporting some patients in caregiver laps. New York State and regional EMS procedures currently lack clear direction for the pediatric patient transport, which only further enables incorrect practices and misinformation. Some final thoughts from the study. Fewer than 1 in 4 pediatric patients are being secured correctly during transports. patients are still being transported in infant bucket seats and caregiver laps, which is out of compliance with NHTSA guidelines. There is a clear need for education, access, and practice to address the non-uniform and potentially dangerous practices occurring during patient transports. A final thank you to all of our wonderful team members and various Albany Med personnel and departments for making CARSEAT a reality. Thank you for your time and your attention.